I'll just quickly say I'm primarily a clinician, okay, and for the last 14 years I've spent most days treating PTSD in one way or another. We are lucky enough yesterday to hear from the foremost PTSD researchers in Australia, and again a renowned international academic, presented us with the latest findings in PTSD and postulated on future directions in diagnosis and treatment. Now, whilst I endeavour to keep up to date as much as possible with the latest research around the topic, I'm not an academic. I also need to keep abreast of what is happening outside of formal scientific research and work, and by learning through my patients, sort out the relative merits of as yet unproven or less evidence-based treatments. I spend most of my time attempting to successfully apply the proven knowledge and a plethora of other therapeutic opportunities to people suffering from this condition that are sitting in front of me. So today I will attempt to show you some guiding principles of how I go about collating all this science and trying to correctly fit them to a patient and hopefully make a positive difference in their life. This is the way that I do it. This is not the right way. There are all members of treaters in this room, and please don't feel that this talk is in any way giving you instruction on how to treat it. It's just the way that I do it. As long as humans have had the ability to record history, we can find reference to post-traumatic stress disorder. Over history, human wars and conflicts, as well as major disasters, have been notable events and so have been recorded. But they've also caused great loss and resulted in prolonged anguish and suffering for many. Large cohorts of traumatised people have always led to a certain proportion, though not more than 25%, as we occurred yesterday, of people having problems adjusting psychologically. And as a result, this has stimulated study into what underlies this reaction and the best way to ameliorate it. The most important conflicts in terms of understanding of PTSD have been the American Civil War, World War I, World War II, and Vietnam. Currently, we are in another cycle of very active research, given the global involvement in the protracted conflicts in the Middle East. History will no doubt also note that these conflicts were critical in our blossoming understanding of PTSD. Each week, new publications or research appear from around the world. Clinical guideline documents are produced from various countries and institutes and continually revised, and expert opinions are extolled through the media on a regular basis. Even though we have the same knowledge base to peruse, people who treat PTSD's individual interpretation of this knowledge varies incredibly, and is very much informed by their experience in treating PTSD and their own biases, which may or may not be based on what is best for the patient. How then does a sufferer navigate the mixed messages that they receive, which result from differing or worse still conflicting treatment ideologies? What does the family doctor say? And how does this correlate with the message that they're getting from a medical officer at work or the psychiatrist? How does what the medicos say compare with what the psychologist, the counsellor, the HSO, the padre, the occupational health and safety person, how does it compare with what they say? What about the well-meaning advice of advocates, the RSL, Mates for Mates, Soldier On, police union, etc.? And what about the workplace? What does the ADF say? What does the QPS, QAS, or the police, the ambulance service, the fire and rescue service? Or what about treaters or funders like DVA and WorkCover? And most importantly, what does the wife say? What does the family say? What do the mates say? So all these messages have to be taken on board by an individual we've got to remember is vulnerable, confused, and has lost faith in humanity and the ability to trust. So when faced with difficult situations, we're often told to return to basics and fall back on what has previously been tried and found to be true solutions. So on this occasion, I've fallen back on the tenets of an ancient wisdom. And no, this isn't Sandy McFarlane. This is Hippocrates, and he has informed my profession for over 2,500 years. Hippocrates is often regarded as the father of medicine in Western culture. And he produced in the late 5th century BC a thesis on the ethics and attitudes forming the foundation of the profession of treating the sick. These writings, when translated, were found to be an oath that would be performed before the ancient gods as a rite of passage for the physician. Whilst modernised in a minor way to make it relevant to practice these days, it's really changed very little, and it's still every bit as relevant to best practice today. So we have a modernised version of the oath, and on the left is a modernised version of Hippocrates. Interesting. So the first tenet is to respect knowledge and science that comes from the Hippocratic Oath. So with the peaks of interest in PTSD throughout history, researchers and treaters alike have often found themselves repeatedly revisiting concepts previously deduced, and rather than learning from history and building on prior concepts, we've tended to reinvent the wheel. This needs to change so we can move forward. We need to understand that our ability to unlock the secrets of PTSD, however, is significantly hamstrung by our improving but still only superficial understanding of the most complex structure known to man, which is the human brain. Even still, however, PTSD lags somewhat behind other psychiatric conditions definitely in terms of drug options and universally effective and tolerable counselling techniques. But yesterday we were brought into the 21st century in terms of some of the latest research, the science and directions in PTSD diagnosis and treatment. It is this research which provides the current treatments, which, when applied correctly and given appropriate amounts of time, are leading to significant and sustained recoveries in the majority of patients. Research remains active worldwide, and new discoveries are occurring at an increasing rate in this space, offering real hope for superior understanding of and therapies in the not too distant future. So, a second tenet, and this is an important one: there is an art to medicine. Warmth and compassion may outweigh the surgeon's knife or the chemist's drug. Hippocrates also introduced us to the concept of the rule of thirds, which actually was brought up yesterday. And the rule of thirds states, he even knew back then, that a third of patients really benefit from treatment. A third get better on their own, and a third don't respond or get better. In PTSD outcomes, this scenario rings true with available treatments at the moment. So a third recover, a third respond but have ongoing symptoms, and a third do not respond to treatment. Unfortunately, we have a few problems applying Hippocrates' rule in PTSD with these figures, because we still know that up to 50% of those with PTSD don't volunteer their symptoms or their illness and never really get a chance at good treatment. So this is a significant problem for us. As David Forbes referred to yesterday, we need to be careful when translating research findings to clinical practice. How do research populations really correlate with real patients? It is established that research cohorts, or people that are involved in clinical trials, are generally a more motivated population, have less physical and psychological associated illness, have less severe or acute illness, and less substance abuse, etc. Research, in fact, into this shows that only about 10% of treatment populations would meet the typical inclusion criteria to be involved in a clinical trial. So we have to remember that. Research and experience also inform us that there are certain elements that continue to defy explanation but play a absolutely critical role in treatment outcome. And examples of this are hope, unconditional positive regard or validation, a therapeutic fit between the sufferer and the listener or treater, and a trust and belief that a treatment will work. All of these things play a discernible role in outcomes. So the art of medicine or therapy in PTSD involves a compassionate and validating approach, effectively building trust, harnessing hope, and being a consistent presence so that we can identify markers in an individual which guide the flexible application of one or more of a number of treatment methodologies. One of the gods to whom the Hippocratic Oath was sworn before was Panacea, who was the ancient Greek goddess of universal remedies. Panacea now refers to a cure-all or a universal remedy, something that currently does not exist in PTSD. So, the next tenet is knowing what we don't know and respecting when the skills of another are required for patient recovery. Hence, researchers and clinicians and all who work with PTSD need to accept, respect, and continue to evaluate the relative benefits of other alternative, complementary, second line, whatever you want to call them, therapeutic initiatives, as standalone treatments or ones that augment current treatment. By blinkering ourselves to these options, we limit the patient's options and potentially limit the patient's outcomes. We fail to innovate, and we may miss the boat on the next big thing in PTSD treatment. As doctors, we make decisions about drugs based on efficacy, which is how successful a treatment has been or shown to be in research, versus tolerability. What are the adverse side effects? With these as yet unproven treatments, we can't really definitively comment on their global effectiveness, but what we can almost certainly say is that they are more tolerable than their evidence-based counterparts at this point, and they have other intrinsic benefits, which we'll come to. So many of these methods utilise concepts which make a lot of sense, like peer-to-peer or group approaches, which use the power of the lived experience or shared adversity, and social connectivity. The use of animals to reopen emotional channels, provide unconditional devotion, and encourage the ability to trust and bond again. Using goal or achievement-based activities to build self-efficacy. Using partners and families. All these things are so important. It's for this reason that I'm excited about our breakout sessions that are going to go later this morning, where we'll have a chance to see what is happening outside of the evidence-based scientific approaches, but it should be noted that a lot of these methods are in the process of creating an evidence base of their own, and we watch this space with great interest. The next tenet is that prevention is better than cure. So trauma is an unavoidable consequence of many occupations in military, emergency services, correctional services, etc., and in fact in life, because trauma, or PTSD level trauma, has been said to affect around 2/3, for instance, of the Australian population in their lifetime. So we need to make changes at numerous levels. Political level, so informed and considered decisions about where we send our young people and in what roles, making funds available to prepare them appropriately, to better identify those at risk, and then better identify those who have early signs of illness, and get in and treat them early. At a community level, we need to increase community awareness. We need to educate on mental illness treatments and a rehabilitative approach. We need to reduce barriers to care, particularly things like stigma, and encourage people to volunteer symptoms without fear of prejudice or reprisal. with respect to their occupation, their financial stability, their social status. We need to improve the accessibility of treatment. And at an individual level, the understanding and researching that's further that we need to do regarding protective factors in PTSD, resilience training, things like finding markers of response, all this kind of stuff. This is an eloquent quote by Hippocrates that it is far more important to know what person the disease has than what disease the person has. And it speaks to the final tenet today. I do not treat a chart or an illness, but a person. Each PTSD sufferer has a previous life, ideas, aspirations, and has loved ones, current obligations, a past career, future aspirations, all of which may influence the presentation of their PTSD and their choice of what treatment is going to be most effective. So given our current understanding of PTSD, no matter what the research tells us, we should not tailor a patient to a specific treatment, but rather any number of specific treatment options to that individual patient. These decisions should be informed by research and neuroscience and established predictors of treatment response, but ultimately determined by decisions made collaboratively within the treatment dyad, the patient and the treater. Individuals need to be at the centre of their care, enjoy an alliance with their treater based on trust and mutual respect, and need to feel that with instruction from their treaters that they're driving their own treatment. Finally, I want to end on a positive note, echoing what many have already said at the forum today, but also what I've experienced over my years in treating PTSD. People with PTSD get better, but in my experience it takes time. Our current treatments effectively remove PTSD from a full third of patients and make another third of patients better, considerably better. But there is that 30% who don't respond. But that doesn't mean they won't respond to treatments which may and which will eventuate in the future. So in the interim, we'll take from Hippocrates one final time, and we'll treat often, we'll cure sometimes, but we'll comfort always. Thank you.